Welcome everyone to the 6th Community of Practice webinar. I'm Francine Maloney and I'll be your host and one of the presenters for today's webinar. First of all, we just really like to thank you all for taking time out of your schedule and joining us today. As I mentioned a few minutes ago, Rachelle and I are just really excited to talk about, give an overview or an introduction to the serious illness care program. We know that there's lots of people who have joined the community and are interested in some of the higher level goals of the program and sort of the why, what, and how on a high level of the program and what it is the goals and mission are. So that's the objective, or the high level objective of today's webinar. Before we really jump in and get started, we do always like to go through some webinar functionality. And the goal of doing this is because we really hope that this webinar will be interactive as much as possible and not just a didactic session. So quickly to run through, on the left-hand side of your screen, you should see a few different options, one being a chat. Sorry, the right-hand side of your screen. So one should be a chat function, another a Q&A, and then there might be a polling, which we will get to a little bit. We'll ask you some polling questions. If you don't see those options open on the right-hand side, at the top bar, again on the right-hand side, you will see the little icons like you do in this image. And if you click on that chat or Q&A, then those options open for you. And you should always feel free to chat us anytime. You can chat to just the panelists if you would like to. You can chat to all of the participants, and the same goes for the Q&A. We will keep the phone lines on mute just to cut down on background noise throughout the presentation, but we do have times for open discussion and questions or comments, your own experiences with the program. And so in order to unmute your lines, we just ask you to raise your hand. That is under the participant tab. There's a little hand raising guy. You can see the little hand raising on your screen maybe there under the participant tab. And if you just raise your hand, we'll do our best to unmute your line. Again, if you don't feel comfortable or you're not in a location, you can always chat or Q&A, and we can share your comments or questions as well over the line. So feel free throughout the webinar to interact with us. We always find it more enjoyable for anyone. If at any point you have any technical questions or concerns, please feel free to use the chat to host function, and we can assist you directly that way as well. So that's our housekeeping. So that you know who's on the other end of this line, and we're not just voices. So I am Francine Maloney, as I mentioned. Today I will be your host for the event, as well as the presenter, and then there's Rachelle Bernacki, who is our clinical lead for the serious illness community of practice. And she will also be presenting for this webinar as well. I'd like to say in the room as well we have some support. So we have Cayenne in the room who is helping on the technical side, and if you do chat in, she will help make sure any of your questions are answered if you're having trouble with WebEx. And we have Jim in here as well to help. So if you hear other voices or other people responding to you, that's who's here. And mostly if you do use the Community of Practice website, you'll hear a lot from Rachelle or myself. So if you ever have questions, please feel free to reach out to us directly. We're always here to help support your goals and implementation. So what we did in the last webinar, for those of you who couldn't make it, the topic was about a model EHR documentation system to support the serious illness care program. And really, we explored the current state of ACP documentation. We ideated on the future state. We identified gaps in a pathway to improving ACP documentation in an EHR, and we reviewed barriers and lessons learned. And it really was a great webinar. Dr. Pippa Schulman from Atrius Health led that discussion, and it is available on our Community of Practice website for people to view. Both the entire recording and the slides are available. In the scheme of today's objective, this goes more into the how, and it's very deeper dive into one of the aspects of the how, so we won't get that specific today. In terms of today's objectives, one is to describe the Serious Illness Conversation Guide, and so that people have a sense of what that is. It is a structured, evidence-based approach for patient-clinician conversations about values, goals, and choices for patients with serious illness. And then, of course, to provide an overview of the program. And that part is really the system change components to help facilitate the use of the conversation guide. I hope that helps to ground everyone in today's objectives. So before we dive in more about the Serious Illness Care Program and the conversation guide itself, we thought it might be helpful to provide you a little bit of information about who we are at Ariadne Labs and what it is that we do. Whenever I talk about Ariadne Labs, a lot of the time the first question, or people think what we do is a lot of pharmaceuticals, so it's a misnomer. We're not a bio lab. We're a health innovation lab. And this is our lab. This is what it looks like in our office. You can see it's a little bit casual and a little bit, we could probably clean up before we take a picture next time. But it is what it's like to be here every day. It's an open workspace to promote conversation and thinking and collaboration. And our mission here is to create scalable healthcare solutions that deliver better care at the most critical moments in people's lives everywhere. And what that means practically when I break down our mission is the critical moments are really about when a patient or clinician interfaces with the healthcare system. And those moments right now that our lab focuses on are birth, and we have two programs or projects within that area, one focusing on the undertreatment in birth, and then one focusing on overtreatment. We work in surgery, and our focus there has been on, many of you might be familiar with the WHO Safe Surgical Checklist, and we also have worked in OR crisis manuals. We have worked in the primary care setting, and then we have worked at the end of life or with serious illness care. Those are the critical moments, and most of them are around simple solutions, checklists, conversation guides, things like that, and how to best implement them for everyone around the world, no matter what type of facility or context you're in. So hopefully that's helpful to people who might not be familiar with Ariadne Labs or who's on the other end of this phone. So I'm going to hand it over to Rachelle now. We're going to pass her the ball, and she'll go more into the Serious Illness Care Program. So if I can, yeah.
Thanks so much, Francine. Can people hear me?
We can, Rachelle.
Wonderful. So you'll hear I have a little bit of a cold, but that was a great introduction, Francine, and I'm glad you kind of shared what we're trying to do at Ariadne Labs. The way I like to think about it is we know the right things to do, but we don't know how to make them happen. So some people call it the no-do gap, and that's what we're trying to figure out how to close. So I'm delighted that we have so many participants. Our community is really growing. We have over 1,200, almost 1,300 members now, and we realized that there was a need for people that were coming into the community to understand what our program is about and what we're really trying to do. So this is really an overview. So for some of the participants that have been present for a long time, they may already be familiar with this material, but this is really just to allow those that are new to the program to get a sense of what we're trying to do here. So we know that earlier conversations about patients' values and goals are linked with better serious illness care. So They have increased goal concordant care. That's really just a fancy term to saying, did patients get the kind of care that they want? And so if they said they wanted to die at home, did that happen? If do they have the quality of life that they want? How much time are they spending in the hospital? When do they enroll in hospice? Was it in the last few days of life, or did they have a longer stay in hospice? And better patient and family coping. We also often fail to recognize and honor patients' families' values and goals. And we see that many families, I was just on service last week, and certainly families are in distress because the goals aren't clear. And patients have poor quality of life and unnecessary physical and emotional suffering. And we want to try as much as possible to make the goals clear earlier, and so that we can mitigate that. I don't think we can obviously reduce all suffering to zero, but I think we can certainly make things easier. We want to try to reduce prolonged and undesired hospitalizations and ICU stays. And, the other thing that I think is really important about this work is there's a fair amount of moral distress when clinicians are providing care that they don't feel is really benefiting patients. So we really need to be providing the kind of care that we think is helpful and be clear about what those goals are. And so this program is really a systematic way to make that happen. So here's what we know about conversations, and it's primarily in oncology, mostly because that's where the research has been done, but they're infrequent. Less than a third of patients with end-stage diagnoses have discussions with clinicians about their values and goals. In advanced cancer, at least, the first discussion happens about a month before death, and 55% of those initial discussions occurred in the hospital with a clinician that really doesn't know the patient as well as their outpatient clinician. And then the conversation quality is fairly limited, so it might really focus on just procedures and whether they want particular treatments, and not really about the bigger picture questions of what's really important to that patient and what they care about. The conversations are often not documented well. When I first started this project 7 years ago, I certainly saw that. We worry that there's, even if a discussion does take place, it can be incredibly hard to find it in the medical record. It's oftentimes the documentation is not accurate, and it might conflict with other information in the EMR. So one study showed that the error rate in which the patient's stated preferences did not match was almost 40%. So when you think about that, it's really a concern for patient safety. Are we really providing patients with the kind of care that they want? If we have documentation somewhere in the medical record that the patient doesn't want something, and yet we're doing it, then we really need to make sure that that we have systems in place and fail-safes to make sure that we don't commit those errors. I think there's two different types of harm that can occur. There's the harm of clinicians and the medical team not knowing what the patient wants and therefore not being able to deliver the types of care that they want. And there's also incredible relief of anxiety that happens when these conversations occur well. When a patient is able to share their worries and concerns with the care provider team, when it leads to a closer relationship between that team, but also feeling heard and understood. Then there's the harm of getting unwanted care. So in the absence of knowing what a patient wants, our obligation is to provide everything, potentially CPR, ICU stays, etc. So both of those are major concerns. So in the past several years, there's been an increased national focus on the need to improve communication about values and goals. 9 in 10 Americans believe that doctors should bring this up with patients. but the patients expect us to bring it up. And really, my experience of this is hearing from providers and when I say providers, I mean physicians, and nurse practitioners, PAs, nurses and social workers really don't know how to bring this up or what the right words are to broach this subject. Also, in the past 2 years, advanced care planning conversations can now be reimbursed. The billing codes are listed there. I just reviewed the data for this. People are using these codes, but we have no idea really what the quality of the conversation is and what's included in these conversations. So I think that's where the needle needs to move, really, to really be able to measure that quality and make sure that every patient has the opportunity to discuss what's important and do planning with their clinical teams. So how can we do better? So universal access to high quality patient-centered serious illness conversations, meaning every patient, every time, with the aim of reducing suffering and ensuring receipt of goal consistent care. So, in order to do this, we have to engage our health system leaders. They have to understand it's a problem and also be willing to commit the resources to do it. I think, if you're interested in that more, we do have a webinar about how do we engage leadership, but I think that it essentially, means being able to give kind of the 2-minute elevator pitch about why this is so important. From the clinician standpoint, I think they need better training. Patients, this is a extremely anxiety-provoking topic, and we need to work on ways to reduce the anxiety for patients. And then for families, we need to remind families that their input is absolutely needed, and we want to help them through this as best we can, but we also are trying to do what's best for the patient. So what role does clinicians have in improving patient conversations? So one of the problems that we have is we have a difficult time identifying patients with a serious illness. We've made some progress with Amy Kelly coming up with a definition, but we still don't have sort of universal algorithms to identify, oh, this patient has a serious illness and really would benefit from conversations about values, goals, and preferences. We've used all sorts of ways to try to identify patients, like the surprise question, would you be surprised if this patient died in the next year, and high-risk algorithms, but we still really have some work to do to have a really good system of finding those patients. Then we need to initiate these conversations using best practices in serious illness communication. Opening that conversation can be difficult, and having a script or having some ideas about how to do that is really important. We need to document the discussions in one place in the EMR so that everyone knows where to get it. So we call this the single source of truth, so that every person knows, every provider in the hospital knows, if I want to know what this patient's values and goals, they know to go to a particular location in the EMR and look for it. And also allowing for documentation across disciplines in one location so that we can see this information. I think of it akin to allergies, so we don't have trouble finding the allergies in the chart. We shouldn't have trouble finding the patient's values and goals. For instance, when at Partners, when you click on someone's code status, that opens an advanced care planning module, which has a section included. It has a healthcare proxy, it has pulse, MOLS, living wills, any sort of documents, but it also has a section about the serious illness conversation, so you can read that text to understand more. Then you need to create a care plan in collaboration with the patient, families, and teams so that matches care goals. This is a pretty difficult thing to figure out how to do this. One of our faculty, Daniela Lamas, is working on that right now, but we're trying to come up with a more systematic way to create a care plan so that we can teach people how to do this. And then the other thing is to really set a high example of high quality communication for colleagues, residents, and medical students. So our program includes tools, trainings, and system training changes. The tools include the Serious Illness Conversation Guide. It's available on our website. It has a Creative Commons copyright, which means that as long as you are not using it for profit, you can also use it. If you need to know more details, there's information on the Community of Practice website, and Francine Maloney is really our guru about that copyright. If you're just referencing it in academic literature, you should reference one of our papers, and there's information about how to reference that paper as well. In addition to the guide, we have the clinician reference guide, which is really a lot of scripting about difficult situations. What do I say to my patient when they say, I want to beat this? What do I do when the patient says they just don't want to talk about it? I think those are really difficult conversations to have, and I think clinicians often struggle with what to say. And so this guide, which was, I must credit Susan Block for this, really is a career worth of experience about what the right things to say in those moments are, and I really encourage you to look at it and share it with other people because it's an incredible resource. Patient preparation materials. So, this is probably not a kind of conversation where you just want to spring it on a patient in clinic. So sometimes it might be better to say something like, the next time you come in, I want to talk about kind of overall where we are with your care and where we're going with things. And then this letter is a way to sort of introduce those things. And it says things like, we want to hear what's most important to you. We want to know who we should talk to in case you can't talk to yourself, those kinds of things in that patient preparation material. And then finally, patients often have a difficult time knowing how to open up this conversation with their family members. So we have a very brief guide that gives tips and suggestions and really scripting of how to open up that conversation. Then we have training. It's a 3-hour clinician training. We initially started with 2.5 hours and realized that there's really much more content than we could fit into 2.5 hours. And what that training entails is really hands-on practice. So we start with a brief reflection to sort of center people and sort of take them out of their busy daily lives. And then we give them the data about why this is important. Following that, we demonstrate a conversation using the guide with a clinician and actor. And then we allow people to sort of give their thoughts and feelings about that, their reactions to that. And including negative reactions, I think it's really important to talk about, some people, after the conversation might really feel frustrated that we didn't decide on a code status. And, that's a great discussion to have. I think we as clinicians really worry about what the code status is. And, from a patient standpoint, there's a lot more things that need to be talked about. Do they understand their prognosis? What's the next treatment steps? Those kinds of things. So following that demonstration and debriefing, we then spend over an hour in small groups practicing using the guide. We are in the midst of revising some of that training and putting in some drills to see how that works. But we're really trying to give clinicians some opportunity to practice, a new skill, and then also to get some feedback about their skills and how they can take their skills to the next level. And then the last piece, which is probably where I have spent the majority of my time in implementing these programs, is in system change. So you can have the best training in the world and the most dedicated clinicians, and if they don't work in a system that allows them to seamlessly communicate information and get it to other providers, then all your training and all your well-intentioned clinicians is not going to matter. So we started with these key steps. So one was identifying patients. So for the most part, we've been using the surprise question. We've also been playing around with high-risk algorithms and machine learning to identify patients with serious illness. If people are interested in that more, we have a webinar that we just had a couple of weeks ago and can listen to that. We had a reminder system. So, our clinicians, one of the things I learned by implementing this at Dana-Farber is our clinicians are absolutely wonderful. They are incredibly busy people. So I first worried that I would be known as the nag of Dana-Farber, like, did you have your serious illness conversation today? But what I found is that clinicians really appreciated it. So we had a very manual system of reminding clinicians by emailing them. But what I found was that people actually thanked me and said, I know I should be doing these conversations, and I think they're really important. And just in a regular busy clinic day, they fall to the bottom of the list. So having that, trigger to remember to have the conversation is really helpful. And we also allowed for a lot of flexibility, meaning that, if we triggered someone to have a conversation and they didn't, there can be very good reasons why a clinician won't have a conversation on a particular day. The patient's family isn't there, they got bad news from their CT scan. There's lots of reasons. So giving the clinicians that flexibility, but also being persistent and reminding them to have it until it happens. Then a conversation using the guide, and then a structured documentation in the EMR in one place, and then providing those patient and family support materials. So that's our program. So I am aware that we have a need to define what a serious illness conversation is. And it's a discussion or a series of discussions between a patient and clinician or with serious illness that focuses on values, goals, and care preferences, offers an honest prognosis according to patient preferences, meaning we ask patients how much they want to know, and then we tailor that prognostic disclosure to the patient's preferences of how much they want. And we know that 80 to 90% of patients want to know everything we know about their prognosis. It starts early in the course of illness. One of the things about this project that made me so motivated to do it was that I do clinical palliative care in the hospital, and by and large, that is very late in the course of illness. And a lot of things that can happen in the course of a serious illness can't in the hospital when patient's very seriously ill and potentially dying. So, and I often am delivering news and they're sort of saying, this is the first time we've heard this. And then there isn't much time to kind of do some of that planning. Some of it's very practical, like financial planning. Some of it's very emotional, like saying goodbyes to people or kind of repairing relationships. Some of it's existential. So I think all of those things take time to do. And if you can start a conversation early, it can happen earlier. The other thing is that these conversations really provide the foundation for making decisions about care in the future. And then they really are not a one-time thing. They really should be reviewed and revised over time. So these are iterative conversations. But one of the things that we have hypothesized and probably don't have a ton of data for yet is that once you start the conversations, they continue to evolve over time. So why would we think about doing using a checklist? I think that bridging the gap between the evidence between real-world implementation. So, when you fly, I fly quite a bit, and I'm very happy that my pilot is using a checklist. And so it makes sure that they do all the things they have to do before they take off or land. And it really achieves a higher level of baseline performance. So it ensures that every single person does the critical steps every time. And, I imagine I actually dated someone who was a pilot, and he thought it was incredibly stressful to fly an airplane, and I believe him. So, but likewise, having conversations with patients who are seriously ill about what they care about is also highly stressful. So, I think when I first started this project, there was kind of this concern, like, how can a checklist provide patient-centered care? It's so cookie cutter, but it's really a guide to ask open-ended questions about what patients care about. And really what we're trying to do is to prevent a crash. So I see crashes happen all the time in the hospital when I do palliative care consults. oh, they thought they were doing fine, you know, and maybe the physicians had talked about this before, but the patients and families hadn't heard them. So I think what we're trying to do is move these conversations earlier and upstream. So this is our guide. As you can see, it's set up with a conversation flow on the left-hand side and patient-tested language on the right-hand side. So it has specific components: setting up the conversation, assessing illness, understanding, and preferences, sharing prognosis, exploring key topics, things like critical abilities and trade-offs, which Francine will go through, and then closing the conversation. And then it actually has word-for-word questions that we have tested over time, probably in the version 150 possibly now, about how to ask these questions. With that, I'm going to turn it over to Francine, who is going to take us through setting up the conversation and the questions on the guide.
Thank you, Rachelle. I found it really helpful, again, just to like step back and have your overview of like why we need these conversations, a little bit of, it's not just the tools, but there's a lot of system change components that ensure that the conversations happen. And then for me, I always find it so helpful to go back to the mission. And as you stated, it's to improve the lives of all people with serious illness by increasing meaningful conversations with their clinicians about values and priorities. And that always brings me back to the conversation and what it is, and going back to the guide and reviewing that and the goal of having these conversations, and then how do we make the conversations happen, because they're not going to just happen in the systems that we have currently. We all know the clinicians have the best intentions and want to provide the best care for their patients, so how do we make it happen? So with that, going through the guide a little bit more, we've always found it helpful, and we've heard from many people that just going through the guide and each question, and the rationale to how these questions were made can be helpful to people. So the first thing is, Rachelle mentioned on the left-hand side is sort of the steps, and then on the right-hand side is patient-tested language. So this is the step of setting up the conversation. And that really important point of just introducing the idea to have a conversation with the patient and asking them permission to have the conversation that day. They might not be ready for it, and so asking them if it's okay. And then finally, to introduce the benefits, really saying that the goal is to make sure that I have all of the information I need about what matters most to you, so I can provide you with the care you want, and I can best support your family if they ever have to make decisions for you. Those are really, it's very quick, but it just allows permission to go ahead with the conversation. The next step is about assessing illness, understanding, and preferences. We all know that patients have different preferences for the information they receive. So it is critical that we ask them what their understanding of their illness is right now, and ask them how much information they would like to know. And this is really, the point of this is also to really set you up for the next step, which is prognosis, which I'll go into in a minute, but it will set you up to know what they will like to know about their prognosis. And of course, I'm sure many of you, as your clinicians, you already asked the question about illness understanding, so that in a normal conversation, you're knowing what their understanding is. So you're probably familiar with that as well. So prognosis is the step that we have always found clinicians to be the most uncomfortable with, because not every prognosis is time-based. And so the reason why you now see it on the guide with different types of prognosis is to address that, that need, particularly different types of, different specialties of clinicians. So as Rachelle mentioned, when we're purposely saying clinicians and not physicians, because lots of nurse practitioners or PAs or others use the guide as well. So again, we have the tested language that just stating first that you want to share. I want to share with you my understanding of where things are with your illness. And then these are 3 different examples of prognoses that are on the guide. So one being a time-based prognosis, one being a functional prognosis, and then one being unpredictable, to address the fact that many are unpredictable. And so to be able to provide the patients with the information that will help them frame their goals and priorities, but also addressing the knowledge that we know not everything is time-based. I will say the biggest, if you start to look within it, and it's actually on the left-hand side of the guide, is you will notice that most of these, I think all of them, are framed in a wish, worry, hope, which was the second one? It could be hope, worry, hope, worry. So meaning it starts off like, I wish we were not in this situation, but I'm worried that time may be short as. We have heard over and over that sometimes that is the most valuable teaching tool that comes out of the training sessions, is being able to frame prognosis and the wish, worry, hope, wonder sort of framework. And you can frame any of these prognosis in that framework. So after prognosis, and really, okay, sorry, forgot about that one. So the goal, this is the hardest part, as I said, of the guide. And a lot of the times is where things will start to get rushed through. And what we teach and guide the most is just to allow for silence immediately after giving prognosis. And it is the hardest thing to do as a clinician. But to really it really is therapeutic to give the patient time to process emotions after hearing the difficult news. And then to respond to the emotion by naming it and exploring it more. So saying something like, I can see this is upsetting, tell me more about what you are feeling, or this is really hard to hear, tell me what you're thinking about. I think if you're speaking more than, I think we say 50% of the time, then sort of learning how to be more silent in these conversations and getting at values and goals is really important, but it's a skill to build to. We're not really taught to be so silent in these emotional conversations. So building up, it's really, though, to help frame and build up to goals and fear, or the second part of the guide, which is about values and priorities. And really, when people have now a framework to work within, you can understand how then they can shape their values and priorities, now knowing prognosis or whatever type of information preference they would like to know. So the first question in the goals and priorities is around goals, and that is done on purpose, and it's because it's a positive framing question. So the question is, what are your most important goals if your health situation worsens? And then the question following that is fears. What are your biggest fears and worries about the future with your health? And what you will notice in this entire section is that all of the questions are open-ended. And again, this is really important, especially if you are ever thinking of adapting the guide, not to go through. So the third question is what gives you strength as you think about the future with your illness? This question was not actually on the original guide, and Rachelle can even explain that more. So the original guide, meaning what was tested at the Dana-Farber. This question was added when we did more implementation work in South Carolina, and when more people started to use it, the initial response was, there's nothing on here about God or faith, and that was true. So this question was added, and it really does allow for patients to speak more to maybe it's faith, but maybe it's family or other things. So this is the question that often elicits that response for patients. The following question is about critical abilities, trade-offs, and sorry, these are the following 3 questions that wrap up the section. So the next one is, what abilities are so critical to your life that you can't imagine living without them? Next one is, if you become sicker, how much more are you willing to go through for the possibility of gaining more time? And then finally, how much does your family know about these priorities? What we often hear many times is, particularly around the trade-off question, is from clinicians that the patients won't understand what that means, and they won't be able to provide answers to trade-offs. But when tested with patients, they understand it, and it works very well, and they can give pretty concrete answers. And so our advice is often like, try it. You might be right in your setting that it might not work with your patient population, but maybe try it first and see how they respond. And oftentimes we find that they can give pretty useful answers to that question. And as Rachelle said, the final session is closing the conversation, so summarizing what you've heard so that you can make sure that you heard what they have said, and maybe they can correct you if you misheard. Make a recommendation, and again, this doesn't have to be a change in medications. We often start the conversation with no decisions need to be made today, but maybe a recommendation to be, we'll follow up this conversation in a few weeks, or maybe we can bring a family member in next time. And then finally, a firm commitment. And again, this is a really important piece. Oftentimes, patients feel worried and anxious that they will lose their provider in this process or feel abandonment. So just affirming that you're going to stay with it, or you will do everything you can to help them during this time. Again, the last 2 pieces are just the first being documenting the conversation. Rachelle went over this pretty well, the importance of making sure all of the information is in an accessible location in the EHR. And again, this is just the same as allergies. We wouldn't want someone's allergy to be missed, and we wouldn't want someone's priorities and values to be missed by another healthcare provider as well. I saw some questions, and I want to be able to answer them quickly before moving to the next section. But I also want to mention that we do have a webinar on adaptation, and we really do believe that the guide should be adapted to local context, and that's actually why the Creative Commons license is there. And at the same time, there's been a lot of rationale and patient-tested language that went into it. So oftentimes our first piece of advice is to try it and see what works and doesn't work for your context, and then change it. And then keep the spirit of the guide if you do change it. So for example, keep the sections, look at how the wording is, but make sure that they're open-ended questions, because as soon as you do a closed-ended question, you're not going to get the same answers or information that you do from this conversation if you do a closed-ended question. What we've found, again, over and over, is a lot of times people change it or take things out, and then they end up putting it back in. And before I hand it back over to Rachelle, just another small lesson learned is just to remember that we're not trying to make expert palliative care doctors through the use of this guide. Meaning we know that people like Rachelle, who's a palliative care doctor, and others probably would take this guide and make basically the clinician reference guide out of it, but that's not the end goal. so really thinking about that when making the guide and making sure that it meets the mission and goals, but not making it too complicated. So Jennifer, I see that you asked, do you go through the conversation components rationale before or after the clinician after demonstration? Rachelle, you can, I don't know in the order of the training, I think we go through it before in the clinician training. Is Rachelle unmuted?
Yeah.
Rachelle, do you remember if it's before or after?
Can you repeat the question? I was just trying to look for it. Yeah.
Do we go through the conversation guide components with the rationale before or after the clinician after demo in a training?
We talk about the rationale before the demo. Yeah.
Yeah, I thought so. Okay. And then the other question in terms, actually, I'll answer that one after. I'll hand this back over to Rachelle now to complete the rest of the webinar.
Okay, fantastic. So we are conducting research to know how well our program is working in different settings. We've conducted a randomized controlled design trial at Dana-Farber, and we'll be publishing those results soon. We've also had work at the Atrius Healthcare. We published the results of our implementation trial in high-risk primary care. That was working with a group of PCPs and high-risk care manager RNs. It was published in July, and it's available on our community of practice website. We also, and in that paper, we saw more conversations, and they were better. Interestingly enough, in primary care, we didn't see, in comparison to our the non-implementation group, earlier conversations. However, in oncology, we did. In oncology, we saw more conversations. They were better, and they occurred earlier. We've also run feasibility and accessibility trials. Daniela Lamas, who's a critical care physician in our group, used the adaptive version of our guide with patients with chronic critical illness at a LTAC, a long-term care acute hospital. We've also tested the guide that was done by Justin Sanders in African-American patients in South Carolina, and like Francine mentioned, we added the strength question. We are in the midst of getting some data out about our nephrology pilot at Brigham, and then we've also implemented in the UK. One of the great things about this program is we think it fulfills the quadruple aim, which is better population health, and meaning every patient every time, that we have sustainable training and system changes, that the patient experience is better. I didn't mention this earlier, but we, in the Dana-Farber trial, saw reduced anxiety and depression in our patients that had conversations with their clinician. In our ICMP trial, we saw some reduction in costs for patients that had conversations versus those that did not. And so we believe it leads to more appropriate resource use. And then we also think that it may bolster clinician satisfaction and maybe offer some protection against burnout. We don't have any data to suggest that, but we certainly are interested to hear about that. We have an implementation roadmap of our program. As you can see, there's a lot of planning involved in making these steps happen. Just simply identifying patients and administering the surprise question sounds simple in theory, but in practice it can be hard to get your PCPs to actually do this. And so we have a lot of experience in tricks of the trade of trying to get people to actually deliver on doing these steps. You know, we actually, as you can see, phase 2, there's still a lot of work modifying the EHR, getting ready for measurement, et cetera. And you can see training doesn't happen until phase 3. So really there's a lot of upfront work that if you really want to create a sustainable program and true system change to get more earlier and better conversations happening, there's a long road that you need to take to get ready for that. Like I said earlier, training alone is really just not enough. And then the last component, which is expand and sustain. That's incredibly important. We are probably in that phase now in our primary care work at Brigham and Women's, and this is a hard phase, keeping the momentum up and keeping people doing conversations and thinking about how to continually improve and refine the program is an incredibly important phase of this kind of work. Okay, I'm going to pass it back over to Francine now.
Thank you so much. And just to reiterate sort of what Rachelle just said, that roadmap is a great visual and what we dive into more in some of the other webinars. So that really dives into how do you get and plan for the conversations to happen. And so a lot of our other webinars dive deeply into some of those. I shift it back a slide for us into, you see in the blue ribbon, the blue area of the ribbon is Modify EHR, which was a webinar last time, and really how do we get these conversations to happen and create the system, as Rachelle said earlier, so that the system supports clinicians in having these conversations. So that's not just another training that gets conducted and the system isn't set up for them to happen long term, which again is our goal here. So I just want to go through quickly, and I want you all to know, please, actually, sorry, I want to go through the slides first, because I think it will help answer some of the questions that we're seeing, but continue to send the questions in. The first thing is we really invite you all to join our community of practice, and this is the Serious Illness Community of Practice. It's free to join. You'll have access to videos of demonstrations of the conversation guide and other things that you can definitely use in training. Webinars that we've been talking about, including this one, will be up within a few days or a week. Materials. So I know a few of you have asked about the patient prep and the clinician reference guide. Those are all available only on the Community of Practice website. On our main Ariadne website, it's just the conversation guide because we like to create a community around this and hear people's experiences. So we have our community base here. So those are the tools, but there's other materials about how are we creating these systems to help our clinicians and patients, and then the discussion forum so that we can discuss what's working, what's not working, sharing our adaptations. I mentioned the demonstration videos. And then maybe if you're a clinician or you work closely with a clinician, the next step can be two patients who you just know from your clinical experience to have a conversation, a serious illness conversation with. Try out the guide. What seems right about it? Those are that is patient-tested language, but you might have your own way of saying it. So try it out and see if it makes sense to you and how it feels and how it works. So to join the Community of Practice, the link is right here. It's portal.ariadnelabs.org. It's a two-step process, so this is the key. You're going to first create an account if you don't already have one, and then you'll get an email stating that to authenticate your account. You're then going to go back to the portal, the Community of Practice, and you're going to click on the Serious Illness Community of Practice. It's right there, and you're going to request membership. There's a few more pieces of information to fill out to populate the rest of the profile, and then we will accept your request for membership. So it's just a two-step process to join. There's other communities if you're interested in other pieces of our work here, and you can certainly join those communities as well. So again, please feel free to continue to send in your questions. I'm going to try to answer some of them now. Rachelle will make sure that you can answer these. So someone asked, sorry, I'm going through the questions. If we have found differences in the Hispanic population regarding how they accept these conversations. We are working right now. Go ahead, you can answer.
Okay. Oh, it's a fantastic question, and we don't really have the answer yet. We have translated the guide into Spanish. We've had that done both in Connecticut, and we've had a group in Spain do that. But we haven't gone through what I would call formal adaptability testing yet of the Hispanic population. However, we are starting to work on that with a group that we work with in Connecticut. Do you have anything to add, Francine?
No, I was just saying, he said, Francisco, you said you're from Madrid, and we, our other colleagues that contacted us are also from Spain, and we can definitely connect the two of you on the community site to see if you guys can work, you know, could collaborate, because they've drafted a Spanish version of the guide for, particularly for Spain, and then we have more of the Hispanic version of the guide for more like Latino-speaking countries. So we'll be happy to connect you. Yeah, so I will connect you, sorry. So I love this question. Someone asked, would you please say the name of our lab slowly? Yes. So it's Ariadne. Did I say that right? Okay. So it's a Greek mythical goddess. So if that helps you in looking it up. So yeah, Ariadne lab.
Ariadne is the goddess of, she was in a maze, and she was able to navigate her way out of the maze, and that was the reason that the name was chosen. So what we see our role at Ariadne is to sort of navigate our way out of the maze of healthcare. Hopefully that's helpful to some for people remembering.
So a few other questions. Someone asked if we have examples of a guide or script for training. So actually our next webinar, which I will do in about 1 second, is actually on training and coaching, which we haven't talked much about coaching in this particular webinar, but it's an important aspect of our program. Will be on that, which I think you're asking about now. So I would say tune in to come back to the next webinar, or if you can't make it, it'll be posted on the community website afterwards. But it will go through, you know, what is the training curriculum and those things. Let me see if I have others here. Okay, so if we don't answer your questions now, because I'm realizing it's almost to the hour, we will be sure to email you or post them, if possible, onto the Community Practice Forum and tag you so that you know that they're there. We're going to skip that poll. So we're going to start a poll now. We just really want to hear if it was our first time doing this webinar, so it would be great if you can fill out this poll to hear how helpful, if it met your needs, and then if not, what did we miss? What would have been more helpful to hear in this introductory webinar? And just so that you know, if you want to answer the short answer, you just type, oh, yeah, sorry, doing some technical work. the poll should be opening in about a minute, or 10 seconds. There you go. And then while you answer that question, I'll just continue talking. So yeah, our next webinar, as I just mentioned, is actually on Thursday, April 25th. It's the same time, 12 to 1 p.m. Eastern time, and that will be on training and coaching. Again, we've had some other webinars already this series if you want to go back and watch those and dive deeper in a little bit of the how. And we have more coming up, and they end in May. But we start these series, and we really run them through the academic year, because typically from September to May or June, and we take a break for the summer months. So the next one is April 26th, and Rachelle, and actually one of our colleagues working in Canada, in British Columbia, John Yu, will join and be a presenter as well, because they've now been doing a lot of training. So we just really want to thank you all for joining us today. I apologize that we're a minute over. Please feel free to continue to send questions in. All webinars are always available on the Community of Practice website. So if you can't make them, you can always find the webinar and the slides there. Yes, feel free to email us with questions, and we're always happy to help you. Thank you so much.